Okay, so for our project, we looked at an article called The Fortification of Breast Milk with Preterm Formula Powder versus Human Milk Fortifier in Preterm Neonates. It was a randomized non-inferiority trial. And I'm Martha, and I worked with Bree Sutter and Melissa Heinz. So, the title of the article is obviously what I just said, the fortification of breast milk with preterm formula versus human milk fortifier in preterm neonates. The article looked at whether or not the fortification of expressed breast milk by preterm formula has the same effects as the fortification of human milk fortifier in relation to short-term weight gain in very low birth weight neonates. This study was done between December 2017 to June 2019 at a level 3 neonatal unit in India. Our motivation for reading this article is our interest in neonate nutrition and which formula fortifier is the best for neonates. So the author's primary research question was whether or not expressed breast milk by preterm formula is non-inferior to fortification by human milk fortifier in terms of short-term weight gain in very low birth weight neonates. This means that the authors were looking at whether or not expressed breast milk by preterm formula powder has the same benefits as fortification by human milk fortifier when given to very low birth weight neonates. Um, to demonstrate that fortification of expressed breast milk by preterm formula powder is non-inferior um, to fortification by human milk fortification in terms of short-term weight gain. Um, so this is an open label non-inferiority randomized trial that was conducted from December 2017 to June 2019 at a level 3 neonatal unit in India. The trial enrolled preterm, meaning born at or before 34 weeks of gestation, very low birth weight neonates receiving at least 100 milliliters per kilogram per day of feeds and consuming 75% of milk or more as expressed breast milk. The neonates were randomly assigned to receive fortification by either preterm formula or human or preterm fortifier or human milk fortifier. Calcium, phosphorus, iron, vitamin D, and multivitamins were supplemented in the preterm fortification and only vitamin D in the human milk fortification group to meet the recommended dietary allowances. The primary outcome was the weight gain until discharge from the hospital or 40 weeks post-menstrual age, whichever was earlier. The pre-specified non-inferiority margin was 2 grams per kilogram per day. Secondary outcomes included morbidities such as necrotizing enterocolitis, feed intolerance, and extrauterine growth restriction.
So the statistical methods that were used and the results that were reported appeared to be pretty thorough. The authors outlined the statistical analyses used and which data points the tests were used on. The data itself was thoroughly and completely reported. The authors also stated the full name of each statistical test. For example, they used the student test instead of the Simply T test. They also identified the specific program used as Stata version 15.1. The researchers stated all the raw data used and each option they selected. This makes their reporting thorough because the results are replicable. All these factors point towards thorough reporting of statistical methods and results by the authors. The main takeaways and implications that were reported by the authors note that of the 123 neonates that were enrolled, 60 and 63 were randomized to the PTF and HMF groups, respectively. The mean gestation and birth weight which was 1,161 versus 1,119 grams, was very comparable between the two groups. There was no difference in the mean weight gain between the two groups. So therefore, the fortification with preterm formula powder is not inferior to fortification with human milk fortifiers in the preterm neonates. Given the possible reduction in feed intolerance and lower costs, preterm formula might be a better option for fortification, especially in the resource restricted settings.
And then our review of the article, we gave it a 5-star overall rating. And then for strengths and weaknesses, just focusing on strengths, the author of the study reported their data in a clear and concise tables. This makes the study replicable due to the emphasis on reporting upon all the data points. And then the results of the study were well analyzed and clearly reported. And then going for weaknesses, the important limitations were discussed. The sample size does not represent the population of interest due to the small sample size between both groups. The small sample size must be more significant to have a compelling evidence for their conclusion. And then the authors acknowledged several limitations in their study, including lack of blinding, the possibility of performance bias, non inferiority margins, sample size considerations, and then reasons for design choices. And then what did we learn from this article? We learned critical evaluation of evidence, as in the study of fortification of express breast milk highlights the importance of critically evaluating both the benefits and limitations of different interventions. And then resource management and cost effectiveness. It highlights the significance of cost benefit analysis, usually an approach that can be applied to many areas of life, not just healthcare, also like finance, project management, in areas where resources are limited. Scientific communication, the way the article presents its findings, also offers insight into scientific communication within presenting both sides of an argument clearly and including the benefits and limitations. And then lastly, they had ethical considerations and public health impact. From a public health perspective, this article draws attention to ethical dilemmas of using more expensive, potentially less accessible solutions when cheaper, more practical alternatives also may be available. So we kind of learned a lot from this article. And then here are our references.